whereas the lower GI tract includes the distal part of the small intestine, including jejunum and the ileum and the large intestine and the rectum. So upper GI bleeding usually comes from results from esophagus, as in esophageal varices, or a stomach, as in gastric ulcer, or duodenum, as in duodenal ulcer. And for the lower GI bleeding, bleeding occurring from the distal part of the GI tract can be from colonic polyposis, where the polyps are protruding into the colonic luminal space, or maybe you have an inflammatory disease such as the inflammatory bowel disease with Crohn's disease or ulcerative colitis, which we will talk about later on, and of course cancer, colorectal cancer, and or hemorrhoids as well. So these signs depend on really how much blood and how fast you are losing blood. So accumulation of blood within the GI tract can be irritating, and thus increasing the peristaltic movement can lead to a rapid transit of intestinal contents resulting in diarrhea. Acute bleeding can be categorized into hematemesis, where you are vomiting blood if it's upper GI, and the melena is the black, grayish, very sticky and tarry stool. And it's because the bleeding probably occurred within the upper GI, where blood had a chance to combine with digestive enzymes and stomach content, converting the red color to a blackish. Anytime you mix acid with blood, it tends to turn blackish. So it's transiting throughout the small intestine and the large intestine and sits inside your GI tract for at least 10 hours. So as a result, your stool becomes black and very, very sticky to an extent. Hematochezia is often when you see fresh blood, so red fresh blood in your stool. So we are often suspecting maybe the bleeding is in the lower part of the GI, or fresh bleeding from the colon due to ulcer, or maybe due to a cancer within the colon and such. And lastly, we have occult bleeding. Occult means hidden blood. So you might see a tiny trace amounts of blood passed in normal looking stool. So it's kind of hidden in your stool, very hard to detect in this case. We have cleft lip and cleft palate. So let's talk about this. Frequently occurring in combination can be on one side or both sides, and probably there is a multifactorial pattern of inheritance, so from a genetic predisposition from the parents, and can be surgically corrected. Disorders of the oral cavity, we have stomatitis. Stomato means the mouth, so we have an inflammation of the mouth or the oral cavity, and canker sores are the small painful ulcer formations within the oral cavity. Periodontitis, inflammation of odonto, is the teeth, and peri means the surrounding area. So infection is often associated with the surrounding structures, such as the roots of your teeth. And then gingival is the gum tissue, so inflammation of the gums, as in gingivitis. And pyorrhea, rhea is a discharge, and pyo is a pus formation, so you have purulent discharge from the gum tissue. Then you have the periapical abscess, where you have abscessed the tooth, and dental caries is just a fancy term for tooth decay. Dysphagia is difficulty swallowing. We can have mechanical obstruction or functional disorder. For mechanical obstruction, can be originating from within the esophageal wall or the lumen space. So in this case, it's the intrinsic etiology. If there's an esophageal cancer, or some sort of a failure to relax, as in stricture, or can be extrinsic in nature, where the origin is outside of the esophagus and pushing maybe against the esophageal lumen space. So again, nearby a tumor, which happens to be the most common cause of dysphagia, according to what we know. And for functional disorders, either having a neural or muscular disorder, as in echolalia. Echolalia is where the lower esophageal sphincter fails to relax because of the neural issue. And the next category, we have the diseases of the esophagus. So first example is the carcinoma of the esophagus, or the esophageal tumor. Can possibly invade the surrounding tissues or organs, including trachea. And central necrosis of the tumor can potentially lead to an abnormal opening, such as a fistula. And stricture is just a narrowing caused by scar tissue. And cardiospasm is where you have the lower esophageal sphincter that fails to open open properly, or you can have an incompetent lower esophageal sphincter where it's unable to remain closed properly. So if it's partially open, can lead to reflux esophagitis when the acidic chyme comes over or comes through into the stomach lining. And the GERD is the gastroesophageal reflux disease, and the reflux of chyme from stomach into your esophagus. Physiologic reflux is typically when the acid is coming up into your esophagus, it's going to be neutralized and probably cleared within a few minutes. And the reflux esophagitis is a little bit more serious because it's more recurrent and can lead to an inflammatory response. What are some causes of GERD? Frequent vomiting and coughing, or lifting heavier weights or bending, which all can increase the abdominal pressure. And of course, pregnancy is another cause of GERD. And severity of reflux disease can really depend on the gastric contents and the length of time in contact with the esophageal mucosa. Risk factors: individuals with weak esophageal peristaltic movement, or having that pre-existing gastric or duodenal ulcers, and strictures that can narrow down the distal part of the stomach, the pyloric region, or having a hiatal hernia, where part of the stomach protrudes into the thoracic cavity to weaken the lower esophageal sphincter. So let's talk about hiatal hernia. We have two primary types. We have this part of the stomach protruding into the thoracic cavity. So this is the sliding hernia, and there's a second opening within the diaphragm that leads to the paraesophageal hernia. So let's go back. We have two types of hernia, or the hiatal hernia, where the upper portion of the stomach simply protrudes into the thoracic cavity through the diaphragm. The sliding hiatal hernia is through the normal esophageal hiatus, can be worsened by coughing or bending or having ascites or due to pregnancy. Paraesophageal hiatal hernia, there's a second opening in the diaphragm, and in this case, strangulation is a potential danger. Signs can be anywhere from having no symptoms to having reflux and difficulty in swallowing, having the heartburn or discomfort behind the sternum. And other examples of esophageal disorders, again, where the lower esophageal sphincter fails to relax, as in achalasia, or can have the esophageal varices with the veins that are dilated. Acute gastritis, acute meaning that there is an erosion of the surface of the epithelial layer within the gastric mucosa. Erosions are typically very superficial and fails to penetrate deep into the muscularis mucosae. And gastritis can happen anywhere, or a widespread, diffuse, or simply localized at few locations. Result of injury to the protective mucosal barrier can happen from using excessive non-steroidal anti-inflammatory drugs such as Advil, or from severe alcohol consumption or use of medications, or having metabolic disorders such as uremia, where the urine substance is excessive or accumulating in concentration in your blood. So the next one, chronic gastritis. So in the chronic case, it's no longer erosion of the superficial layer, but much deeper layers are going to be affected. So we have fundal versus the antral gastritis for chronic gastritis. So again, you have the thinning and the degenerative changes of the stomach wall. It's just so that we are clear on these anatomical terms. Let's quickly recap. So here is the esophagus and the cardiac sphincter, also known as the lower esophageal sphincter. And this dome-shaped structure is the fundus of the stomach. You have the body of the stomach, and the distal part of the stomach is the antrum, and the most distal part of the stomach within the antral cavity is the pyloric region. And you also have another sphincter right here that guards the exit of chyme into your duodenum, the pyloric sphincter. Then you have the lesser curvature and the greater curvature. So the first type is the fundal, or the fundus gastritis. So here is the fundal or the atrophic gastritis, and most commonly affecting the elderly population. You're going to lose the cells that the parietal cells and the chief cells. And if you recall from anatomy and physiology, parietal cells are responsible for the production of hydrochloric acid and also for the secretion of the intrinsic factor. So if the parietal cells are getting destroyed, then you're going to decrease in acid secretion and also start to lose the intrinsic factor secretion. Now, intrinsic factor is required in order for you to absorb vitamin B12. Vitamin B12 is needed for a proper growth and maturation of red blood cells. So if the red blood cells are immature and not properly grown, you're going to have pernicious anemia because of the lack of vitamin B12 absorption from the intestine. Now, for the enteral gastritis affecting the enteral cavity only, and this one is 4 times more frequent compared to the fundal gastritis. You do tend to have normal acid secretion and intrinsic factor secretion, but the problem is the Helicobacter pylori, or simply known as the H. pylori infection. So this is the type of bacteria that probably affects 60%, 50 to 60% of the world population, and I believe in America anywhere from 40 to 50% of the population has the H. pylori infection, whether we know it or not. So that's almost 1 out of 2 Americans with this disease or with this infection. You can get it from kissing somebody who's already infected or sharing food sources that has been contaminated. So it travels down from your oral cavity into the stomach lining, and it tends to thrive within the acidic environment within the enteral cavity, and it starts to produce its own enzyme urease, and it also breaks down the protective mucosal barrier, so you're more exposed to getting gastritis as a result. And the peptic ulcer is just an ulceration in the protective mucosal lining anywhere within the lower esophagus or in your stomach or in your duodenum. Erosion is just a superficial ulceration that really does not penetrate deep into the muscularis mucosae. So here you have the epithelial layer, you have the basement membrane, and then you have the submucosal or the connective tissue. Then you have the muscularis mucosae. So erosion is very superficial. A true ulcer is when the extension of the damage is much deeper because it's starting to penetrate deep inside. So the gastric acid and the pepsin can digest the much deeper tissues as a result. What are the risk factors for peptic ulcer? Obviously smoking, since smoking stimulates excessive acid production, or habitual use of non-steroidal anti-inflammatory drugs, because they tend to decrease mucus production, so there's less protection for you. And alcohol or caffeine consumption, so drinking a large cup of coffee without any breakfast can exacerbate the peptic ulcer. And then of course the H. pylori infection, producing enzymes such as urease and phospholipases, and also stimulates the hormone gastrin, which leads to excessive hydrochloric acid secretion within the stomach wall lining. And of course having excessive psychological stress can lead to peptic ulcer. And of course there's the family history of peptic ulcer disease that plays a role as well. So gastric ulcer is a type of peptic ulcer, but it happens in the stomach. It's not as common as the other one, the duodenal ulcer, but it's only about 1/4 as common as the duodenal ulcer. Occur equally in both men and women, usually targeting the older age group between 55 and 65, mostly involving the distal part of the stomach, the antrum. And pathophysiology, so the use of NSAIDs and the H. pylori infection can increase the risk. And other factors that have been associated include chronic gastritis or duodenal reflux of bile. Remember that bile is secreted by your gallbladder into the duodenum, so it can easily come back into the gastric lining and affect the. As a result, can lead to gastric ulcers. And the use of some drugs can also increase the risk of having gastric ulcers as well. So ulcers, if you're having pain, it's usually relieved by ingesting food or taking antacids, but tend to be chronic for gastric ulcer patients, because you go through the remission process and then the worsening of symptoms as in exacerbations. So take a look at this gastric ulcer right here. It's starting to really affect the deeper layer of the stomach lining. If it's very severe, it may eventually heal with lots of scar formation. And if lots of scar formation is visible near the pyloric region, may potentially lead to pyloric obstruction. then the ultimate result is just basically perforating through the entire wall, where the gastric contents now can start to leak into the abdominal cavity, which can result in the inflammation of the peritoneum. So peritonitis can be a surgical emergency and really can be fatal if we do not address it. Duodenal ulcers is again another type of peptic ulcer, but it happens in the duodenum, and this is the most common subtype of peptic ulcer. It affects males more versus females, affecting more in younger patients, and has been associated to or linked to type O blood possibly. And I've got a question mark because, again, not everybody accepts that research result. Pathophysiology, inadequate bicarbonate secretion. I will go over this one in a minute, or can be associated with the presence of H. pylori or excessive NSAID intake or smoking. So let's talk about bicarbonate secretion. If you remember from the good old A&P days, carbon dioxide typically combines with water to yield an intermediate compound, the carbonic acid, which readily dissociates into a hydrogen ion and the bicarbonate ion. So bicarbonate is literally the buffering agent for the acid or the hydrogen ion. So now if the bicarbonate secretion is inadequate, then you do not have enough buffering agent to combat against the excessive hydrogen ion, which only increases the acidity or decreases the pH of the gastric content. So that can lead to a duodenal ulcer because of the decreased bicarbonate secretion. So signs of duodenal ulcers, chronic intermittent pain, pain coming and going, usually before the meal, and can relieve pain by intake of food, since it's increasing the pH as food comes into the stomach. First manifestation may be bleeding due to ulcer. Often healing spontaneously, but often recurring within months. So here in this photo, we have two examples of duodenal ulcer. How do we treat peptic ulcers? So giving the person antacids, since the alkaline substance can be used to neutralize the gastric content. But if you take too much of it, large amount of antacids can lead to constipation. Also H2 receptor antagonists. So histamine usually binds to H2 receptor to increase the stomach gas acid secretion. But Zantac or Pepcid can also bind to the same receptor, mimicking the histamine. So instead of increasing acid secretion, these two medications are working against the action of histamine to prevent the severe acid secretion. So these medications can antagonize the what histamine does. And then the proton pump inhibitors. Proton pump is used to manufacture hydrochloric acid. So taking medications such as Prevacid can decrease acid secretion, since it binds to an enzyme in the proton pump in order to inhibit the manufacturing of hydrochloric acid. And of course, take antibiotics if you have H. pylori infection, and also we can resort to surgical treatment as well. Pyloric stenosis. Stenosis means narrowing or blocking of the pyloric region. So these pyloric stenosis can be congenital. The baby is born with this condition due to idiopathic hypertrophy of the pyloric sphincter. So the pyloric sphincter is just too thick and it fails to open up. So instead of passing food into the or chyme into your duodenum, it has nowhere to go but to go in the opposite direction. So usually vomiting can happen in babies, the infants that are born, the newborn babies, upon breastfeeding. If you see the infant vomiting across the room, as in projectile vomiting, after the first feeding of breast milk, that could be a sign that the baby has possibly pyloric stenosis. And it can also be acquired due to presence of peptic ulcers or cancer near the pyloric region. Some of the signs include vague discomfort from stomach fullness because it fails to open up, so you get that fullness feeling, and becoming worse after eating, obviously, because it's not going down where it's supposed to be going down, and later on in the day, and the nausea and the loss of weight because you're not able to absorb the food properly, and as a result, weight loss and stomach distension and vomiting as well. Okay, so intestinal obstruction. Onset can be acute or chronic. If it's acute, maybe a portion of the intestinal lining or intestinal organs, or telescoping or herniation. We will talk about all of these later on. And for chronic case, maybe there is carcinogenesis or maybe progressive stricture. And for the extent, that can be incomplete as in partial, or you can have a complete obstruction. Location can be inside the intestine or outside the intestine. And location can also be higher or as an proximal location involving duodenum and the jejunum, or the distal part of the GI tract involving ileum or the large intestine. Effects on the intestinal wall. Simple means that blood supply is still adequate, and the strangulated means now the blood supply is starting to become affected due to the presence of intestinal obstruction. And closed loop is the worst possible scenario where you have an obstruction at each end of a segment of the bowel. Causes can be mechanical from having a blockage inside or outside the intestinal lining, or can be functional where the paralysis of intestinal musculature can occur due to trauma or inflammation of the peritoneal cavity, or electrolyte imbalance, or even due to spasmolytic agents. Intestinal obstruction can present as an intestinal adhesion where the two structures are stuck together, and this usually occurs in your small bowel or the small intestine, and the 75% of the cases mostly because of the previous abdominal surgery. And the hernia also can involve mostly smaller or the small intestine, and tumor can be anywhere, including large intestine. And volvulus and intussusception. Intussusception is the telescoping of the intestine, may be associated with tumor, and we will talk about these two more extensively after the discussion of hernias. So the first topic, hernias. Definition is a protrusion of a loop of your bowel, most likely your small intestine, through a small opening and protruding into adjacent cavity. So we have three types: inguinal hernia, umbilical hernia, and the femoral hernia. So what you see right here is the inguinal hernia. So here you have the inguinal canal, and that ring into the inguinal canal weakens so that the part of the small intestine is now starting to descend into the scrotal cavity. So a descension of the small intestine is the inguinal hernia. And the umbilical hernia is usually seen where the umbilicus is located, and it's because of the defect in the abdominal wall. And the femoral hernia is below the inguinal ligament, usually happening in your thigh. Under the inguinal ligament, along the femoral vessels are where the femoral vessels are located. So here we see an example of the umbilical hernia, and here again we have the inguinal hernia where the inguinal canal is open because of the weakened wall and the ring or the inguinal ring. So you have a descension of the small intestine, possibly going into the scrotal cavity in males. And now for the femoral hernia that you can see right here is where it's below the inguinal ligament, and that opening is usually along the adjacent femoral blood vessels. Now, any tissue can be contained in the hernial sac. If it's reducible, it means that the herniated loop of bowel can be pushed back into the abdominal cavity. If it's incarcerated, the herniated loop becomes stuck and very difficult to push it back. And if it's strangulated, now blood supply is starting to get compromised. So that herniated loop often becomes necrotic, and it can present as a surgical emergency. Intussusception is the intussusception is the telescoping of the intestinal lining, and volvulus is the strangulation and the twisting of the bowel on itself. So intussusception, telescoping of one segment of bowel into the adjacent segment, usually affecting children between the age of 5 months to 7 months, and that's the most common age in children, usually resulting from a very, very vigorous peristaltic movement. And there has been a close link to pedunculated tumors or tumors of the intestine or within the bowel. Volvulus is where you have the twisting of the bowel on its mesentery. So now, anytime you have that sort of strangulation or twisting, we have to think about, hey, is the blood supply adequate to this loop? If it's compromised, then it can easily die in a matter of time. So if that's the case, it can be a surgical and even a metabolic emergency. Now, next topic is enteritis. So we have acute and the chronic enteritis. So entero means intestine, and it usually involves both a small and the large intestine. Chronic enteritis is less common compared to acute enteritis, and we have two types, chronic ulcerative colitis, and then we have the regional enteritis, also known as the Crohn's disease. So both ulcerative colitis and chronic Crohn's disease are part of the inflammatory bowel disease, and that is not to be confused with the irritable bowel syndrome. Now, irritable bowel syndrome is you ate something that your GI tract did not agree with, so you had pain, bloating, you had diarrhea, and it's over with. Whereas the inflammatory bowel disease, it is a condition, medical condition or medical disease that is here to stay. So you will have two common forms of inflammatory bowel disease. Again, Crohn's disease and the ulcerative colitis. Crohn's disease can affect any part of the GI tract, but it commonly affects the distal part of the small intestine. And ulcerative colitis, as the name implies, primarily targets your large intestine or the colon. So Crohn's disease, you have an ulceration of the mucosal layer, and as it starts to thicken and scar, it can start to affect the motility of the intestinal lining. So again, we have the Crohn's disease when we do the endoscopic examination. So this area, the yellowish area, show exhibiting ulceration and the inflammation. And within the large intestine, when we do the colonoscopy, you can see the ulcerations within the large intestinal lining, leading to inflammation as a result. So ulcerative colitis is a chronic inflammatory disease causing ulcerations of the colon and the rectal mucosal lining. They tend to have recurrent bouts or episodes. Patients are usually younger, between 20 and 40 years of age, with probably a family history. Cause is unknown, but could be jump-started by an infection or genetic or immunologic predisposition. Signs include bleeding or cramping with pain and frequent diarrhea, where large volumes of watery diarrhea is passing through, and can also have nutritional disturbances because of the malabsorption. Appendicitis is the most common surgical emergency of the abdomen, roughly affecting 7 to 12% of the population. And the affected age group is younger, between 20 and 30 years of age. The exact mechanism is probably you have an obstruction on the opening of the appendix, which leads to later on a subsequent infection by the bacteria. And signs are pain, initially very difficult to localize at first, but may eventually migrate to the right lower quadrant where the appendix is located. So initially, we would see it as the referred pain, where it's very distant from the affected organ, and eventually it migrates to the appropriate part of the location, and then we recognize, hey, this could be possibly the appendicitis. And other signs are nausea, vomiting, and fever. So here we have an initial obstruction of the opening of the appendix, and as a result, it starts to become abscessed, and the abscess can actually perforate and rupture, which can be a surgical emergency if the infection starts to spread in the abdominal cavity. Next one is diverticulosis, where we have the presence of outpouchings. So let me just clarify. Colonic polyps, having this condition, or the polyposis, is the inward vagination of these structures. So these polyps are protruding into the lumen space in colonic polyps, whereas in diverticulosis, it's the other way around. So these pouchings are going outward. So if you have one of these, we have diverticula, and if you have two of these or multiple, plural becomes diverticuli, and if you have this condition, you have diverticulosis, and if you have an inflammation, you have diverticulitis. So diverticulosis is the condition of having these outpouchings protruding out. So the outpouchings of the mucosal lining of the colon projecting through the weaker areas in the wall. It increases the risk with low fiber diets, and also can be increased with increased pressure inside the colon, or intracolonic pressure. And diverticulitis is where you have an inflammation or possibly an infection within the outpouchings. So bits of the fecal matter become trapped inside the outpouchings, leading to an inflammation. Complications can be scar tissue formation or further infection, or possibly rupture of the outpouchings and perforation. And surgical resection may be necessary if it's very heavily affected. So we might have to resect and cut out this part of the large intestine as a result. So these arrows are pointing to the outpouchings after we have taken the abdominal x-ray. So I think that's all I've got for you. All right, thank you. relax, and the duodenum and the distal part of the stomach or the antrum go into that spasm. Now you are going to see the reverse of peristalsis. So the chyme moves into the esophagus, and at this point, the upper esophageal sphincter is still closed, and when your diaphragm is forced up into the abdominal cavity, it forces the upper esophageal sphincter to open up, and then you have the strong sympathetic nervous system and the parasympathetic nervous system being both co-stimulated, and with the sympathetic nervous system, heart rate increases, the breathing rate increases, and you start to sweat as in diaphoresis, and with the PNS stimulation, increased salivation, and the gastric motility increases, and the relaxation of both upper and the lower esophageal sphincters occur to trigger vomiting. Constipation is difficult or infrequent defecation, could be part of the neurogenic disorders of large intestine, normally associated with a low residue diet, a low fiber diet, or maybe you're not active enough. Having that sedentary, inactive lifestyle can be associated with hypothyroidism and the consistent suppression of the gastrointestinal motility and the excessive use